So hello everyone, I hope I'm audible and visible. Please give me a quick thumbs up if my audio video is fine. All of you, please give me. Is my audio video fine? Or you can see a little bit of disturbance? All of you. Very nice, all my dear students. I hope you all can see me clearly. Now let's upload the today's file. We have a very interesting session today, and we have a lot of image-based question, which is very helpful for all of you for the preparation of your upcoming exam. So starting with the today's session, let us just upload the file. I hope everyone is doing fine. Chalo ji. So welcome all of you. I'm Dr. Chesta Agarwal, your NEET PG educator on Unacademy, and I've myself scored All India rank 261 in my entrance examination. You're on the best online platform for the preparation of NEET PG, that is Unacademy. We have a lot of Telegram groups. The most popular, there are two Telegram groups. One is NEET PG Live, and second is Let's Crack NEET PG. So please follow us on these Telegram groups for any query or update of the latest courses. We provide two types of subscriptions. One is the Plus, which give you an access to live interactive classes on an academy platform, along with the access to 25,000 plus questions and printed notes. In Iconic, you have an access to both Unacademy and Prep Ladder. Prep Ladder give you an added advantage of clinical integrated essentials, video lectures, question bank, rapid revision courses, and treasure or dream notes. Now we have a very highly updated question bank of around 25,000 plus questions. Please remember this scheme has been extended to 28th of October. So if you take an academy subscription till 28th, you will get 4 month free on 24 month and 2 month free on 12 month subscription. You have to use a code, and code is CHESTA10 for this additional discount. We have one exam remaining for this month, that is a free mock test on 31st for FMG. I request all of you to please be live at 10 a.m. to 1 p.m. on 31st October. We have many new features on Unacademy, like raise a hand feature. If you have any doubt, you can just raise your hand and the educator will answer it. We have new batches which have started yesterday. These are the target NEET PG 2022 batch. Very high demand batch. And I would recommend all of you to take 6 month subscription because you have 1 month free on this 6 month subscription. For this 1 month free, you need to use a code CHESTA10. When you use this code, you will get 1 month free. Along with that, you will also have 10% additional discount. So I request all of you to please be a part of Unacademy. These are the different type of subscriptions. If you take Plus, you have 3 months, 6 months, or even longer. And if you take Iconic, you have 1 month, 1 year, and longer subscriptions. Using the code CHESTA10 on either of sites will give you additional 10% discount. Okay, ji? And for my MBBS students, I would recommend go for 2 years of either Plus or Iconic, which is very cost effective, around 1,500 per month, which is way too cheaper than the other coaching centers. And you have no cost EMIs also. So if you don't want to pay at a stretch, you can just give monthly EMIs for this. Chalo ji, very well done. And now we will be starting the today's session. We have a lot of MCQ. Please give me a quick thumbs up if you're ready for the first question. I'll give you 30 seconds each. Very nice. Umang, Goda, Aim, Minaka, Deepak, Praveen, RJ, Kumar, Prateek, Abhi, Rajat, Shweta, Dr. Kiran, Vishnu, Bindu, Rameshwar, Dr. Surya. Very well done, all my dear students. Now you can see that in this question, they have not given you anything. They have just written that a patient presented to you with cutaneous lesions, and when we did the histopath, we could see some bodies. These are, what are these? Star-shaped asteroid bodies. And star-shaped asteroid bodies are very, very classical of sporotrichosis. Can you tell me what is the feature of chromoblastomycosis? Anyone? What is the feature of chromoblastomycosis? What do you see? In chromoblastomycosis, you see brown color bodies like this. You see brown color bodies like this. Clear, all of you? Very, very important. Chromoblastomycosis. And here you have asteroid bodies, very classical of sporotrichosis. Can you tell me any other feature of sporotrichosis which make it different from other subcutaneous fungus? Clinical appearance which make it different from the other subcutaneous fungus. Please remember, you have lymphatic spread, and that is why you have linear arrangement of the lesions. You have linear arrangement of the lesion which make it different from the other subcutaneous fungus. Can you tell me what is the feature of chromoblastomycosis clinical? How does it appear clinically? Chromoblastomycosis, anyone? Chromoblastomycosis appears like a warty growth, verrucous growth, cauliflower like, very nice. And what about mycetoma? Mycetoma have a characteristic triad of tumefaction, sinuses, and discharging grains. Discharging sinuses, and through the discharge, you'll see grains coming out. So patient with cutaneous lesions, histopathology shows following features. Please remember the correct answer is option number 1, that is sporotrichosis. Very, very amazing, sporotrichosis, and we have discussed all the other 3 examples. Should I go to the next question? Chalo. Again, a pure image based. I would request all of you to please go through the images and then tell me the answer. Which of the following organism causes this lesion? Candida, dermatophyte, actinomycetes, or staphylococcus? I hope the image is visible to all of you. Doctor, I want you to refresh it from your end if you're not able to see it. Which of the following organism causes this lesion? Very nice, everybody, very nice. Please remember, if I zoom this image, you can see that there are multiple sinuses or openings with little bit of swelling, which can be, I think, noticed here. And when you did a histopath, what are these? Are these looking like grape, bunch of grape? Yes or no? So this collections of this collection of pink colored cocci, gram-positive cocci, like a bunch of grape, is very, very classical of staphylococcus. And can you tell me what is the name given to this diagnosis? What is the name given to this condition? It is known as Botryomycosis. It is known as Botryomycosis. So please remember, it looks like a fungal infection, the name mycosis, but it is a misnomer because it is a bacterial infection secondary to staphylococcus. Clear? So this image is very classical. You can see the histopath, you can see the clinical image, and the diagnosis becomes very, very clear. Coming to the next question. Dimple sign can be seen in Vaishnavi, RJ, Namita, Bushra. I can see a lot of old students today. AIM, then Praveen, June, Dr. Tarek, Minaka, Tycho Planet, Dr. Prapanjeshwari, Sara, Abhi. Very nice, and I'm very happy that day by day the number of students are increasing. I request all of you to please follow all my classes. They will be very helpful in the end. As your exams are approaching, you don't have much time left. So again, buckle up your preparations. So this type of dimpling is a very classical feature of dermatofibroma. And what happens here? You have fibroblast proliferation And because of these fibroblasts, you have teethering of the skin. You have teethering of the skin giving rise to dimple sign. Can anybody tell me what is the other name? What is the other name for a dimple sign? What is the other name for dimple sign? What if you get that alternate name? Anybody here can tell me what is the alternate name for dimple sign? Surbhi, Jasmine, Praveen, Doctor, KJ, Karthik, anybody can tell me the answer. Vinita, please remember the alternate name, very nice trichoplanin. It is the Fitzpatrick sign. Fitzpatrick sign is alternate name for dimple sign. Can you tell me Fitzpatrick? He is also, or he has also given one more thing in dermatology. Can you tell me what is that? Fitzpatrick skin type. Very nice, Prapanjeshwari. You have 6 type of Fitzpatrick skin type. Okay, Fitzpatrick skin type. And Fitzpatrick sign is alternate name for dimple sign. So very well done, all of you. I think everybody have understood. Let's move to the next question. Yes, you have teethering of the skin. The fibroblast proliferation, they form the strands and they tether the skin or the epidermis. So whenever you pinch the lesion, it tend to dip in. Slap cheek appearance is a feature of. Slap cheek appearance is a feature of. Erythema infectiosum, exanthema subitum, rubeola, or scarlet fever. This is a pure microbiology question. I only need this image, or I only wanted to show you this image, which is very, very characteristic. Slapped cheek appearance is seen in. Very nice. Please remember, it's a classical name given to erythema infectiosum. Now, what happened in these individuals? They have characteristic sparing of perioral and periocular skin. Only the cheeks are involved, and that is why it is known as slap cheek appearance. The red appearance of the cheek give it as if somebody else slapped the kid. Okay? So the correct answer is option number 1. Anyone has any confusion with this? Yes or no? Anybody has any confusion with this? No. Chalo ji. Now the arrow here shows you something. Okay, so you have to identify the lesion and look at the arrow and tell me what exactly is the arrow showing you. Amazing. Vaishnavi, Shweta, Raj, Prateek, Bushra. You still have time. I request all of you to please read the all options. Now I will tell you one step. Whenever you go and give your exam, use a 3-step procedure to solve a question. Step 1, read the whole question. Step 2, look at the image. And step 3, read all the options. Then you have to mark one answer. It's not like only reading the question will help you in answering. It can help you, but you have to look for the image also. And please read all the 4 options, not only one option. If you think that the option number 1 is right, and you just keep on marking it, that is not the case. That will actually increase your negative marking. So identify this phenomena, or where do you see this phenomena? Please remember, this is a classical pseudocobnus. Can you see that there are lesions in a single line here? Okay, this is also not visible. Maybe the, yes, yellow color is more visible. So presence of the lesions in a line or secondary to the trauma, in the line of trauma, is very, very classical of cobnus. Pseudocobnus actually occurs in viral infection or in infectious condition because of auto-inoculation. Can you tell me what is the diagnosis here? What are these lesions which are seen? Are these what? Are these what? They are not what? They are molluscum contagiosum. They are molluscum contagiosum. Man, please tell about option number 3 and option number 4. Pathergy phenomena tells you that the skin is hypersensitive. It tells that the skin is hypersensitive. And where do you see pathergy phenomena? It is present in neutrophilic dermatosis. Please remember, it is not specific of Behçet's. You can see pathology in pyoderma gangrenosum, in Sweet syndrome, and in Behçet's disease, all three neutrophilic dermatosis. So what happens? Even giving a minor trauma to the skin will cause exaggerated response, and that is because of collection of the neutrophils inside the skin. Understood this? Who have asked me about pathology? Vishnu, please give me a thumbs up if pathology phenomena is clear. Okay? Chalo. What is Lucio phenomena? Now, Lucio phenomena is actually seen in leprosy patient. Lucio phenomena is actually seen in leprosy patient where you have diffuse non-nodular type of leprosy. You have diffuse non-nodular type of leprosy, and it will make patient look more shiny or more beautiful. And this phenomena of appearing beautiful is known as Lucio phenomena. Understood, all of you? So it is a non-nodular diffuse form of leprosy which make the patient skin shine more, known as Lucio phenomena. Now I will ask you one more question. Can you tell me what is Lazarine phenomena or what is Lazarine leprosy? Anyone? What is Lazarine phenomena or Lazarine leprosy? Anyone have heard about this term? Yes or no? I think no. Please remember, Lazarine leprosy is what? Whenever you develop ulcerations on the leprosy plaque, it is known as Lazarine phenomena or Lazarine leprosy, and it occurs because of infiltration of the blood vessels or end arteritis causing necrosis. Understood, all of you? So Lazarine phenomena is also seen in leprosy. Along with that, we have Lucio phenomena, which is seen in leprosy, pathology in neutrophilic dermatosis, pseudococcus infective condition, and Nikolsky sign. It is a feature of intraepidermal acantholytic disorder. Intraepidermal acantholytic disorders like pemphigus vulgaris and pemphigus foliaceus. Understood or not? All the four options. Vishnu, clear? I hope this point is clear. So very, very interesting. And I hope now you will not mark this wrong. And whenever you get the question from this topic, you'll make it right. Chalo ji, badhiya, very nice. Let's move to the next question. A pure image based child with scaly dry skin since birth. Image is shown. What is the diagnosis? Shatnik, Madhu, Jasmine, Minaka, Umang, June, Rameshwar, Rajat, Vishnu, Sachi, Dr. Surya, Surbhi, Praveen, Abhi. A child with scaly dry skin since birth. What does the image shows? What does the image shows? Amazing. The correct answer of the question is option number 3. What is this? Can you tell me what is having or what is the issue in this baby? You can see a very thin glistening membrane which is present over the surface of the skin, known as colloidal membrane. So this membrane is actually a characteristic feature of lamellar ichthyosis. When this membrane is peeled off, the patient can develop dryness, dehydration, temperature dysregulation, even increased risk of secondary infection. And that is why you need to treat them in the ICU setting, these lamellar ichthyosis patients. Very nice. What could be the diagnosis here? So it is not blue. Please remember, the eyes are not blue. I have only used this to hide the eyes. So please, there was once I've shown this image and students told me that, ma'am, this is a blue eye disease. So please remember that blue color is actually the, I've used it to hide the identity of the patient. Very nice. Welcome, Pragya, Babita, Ashish. Different type of ichthyosis, please. Pratik, that is a big topic, and I request you to please take Unacademy subscription, because in my class of genodermatosis, I will be discussing that in detail in my classes, okay? So please take Unacademy subscription, use my code Chesta 10. My plus course is about to start. I would recommend you to go for a shorter subscriptions of either 3 month or 6 month so that you can access all my classes. Okay, Ji. Now there's again and again confusion wala smiley coming. Is there any confusion here? Can you see there is presence of redness, papules, little bit of crust is also visible. And there's one thing which a patient here is showing us. What is she showing? She is showing that the lesion is also present in her eyes. The lesions are also present in her eyes. Now, can you tell me, acne vulgaris, will you have any features in your eyes? Will you have any feature in the eyes? No. Photodermatitis? No. Porphyria? No. This becomes a clear-cut case of rosacea where you have ocular rosacea presenting with meibomitis, scleritis, uveitis, etc. Clear? ठीक है जी. Praveen, Vidyananda, Prapanjeshwari, Shweta, please remember this is a very interesting self-explanatory image where you don't need anything because they have shown you a clear-cut the hint here in the image. The presence of ocular involvement is a very, very important feature in helping the diagnosis of rosacea. Next question, what will be your diagnosis here? What will be your diagnosis here? What will be your diagnosis here? I hope everybody can see the poll. I don't know what happened. Suddenly the poll was crashed. Is it visible or not? Please give me a thumbs up if you all can see the poll. Yes, okay. Okay, Ji. Now here they have two images. This is image number 1 and this is image number 2. Now majority of you, around 76% of you have marked option number 2, that is erythema multiforme. And I think I'm sure that after looking at this image, which is a target lesion, you definitely think about erythema multiforme. But can you explain this image? Do you see any butterfly rash in a patient of erythema multiforme? Or will you see any lesion of butterfly lesion on the face in a patient of erythema multiforme? No, it is a feature of SLE. And please remember, sometimes in SLE, you see target lesions, and that is known as Rowell's disease. That is known as Rowell's disease or Rowell's syndrome. Understood or not? Very, very important. Features of SLE along with erythema multiforme like target lesions, it's a feature of Rowell's disease. Can anyone tell me what is senior Usher syndrome? What is senior Usher syndrome? Anybody? Senior Usher syndrome, very nice, Dr. Tariq. It is features of lupus erythematosus, that is malar rash, photosensitivity, along with features of pemphigus foliaceus, which includes scaling, crusting, etc. Clear? So SLE plus pemphigus foliaceus is senior Usher syndrome. Senior Usher syndrome. Now we have one more question I wanted to ask. Can you tell me what is Fogo Selvagum? Few very weird names I will discuss in next 2 to 3 minutes. What is Fogo Selvagum? Anyone? Yes, very nice. Endemic pemphigus foliaceus is known as Fogo Selvagum, which is seen very commonly in Brazil, not seen in India. Second, what is Ispundia? Have you heard this term in dermatology anywhere? What is Ispundia? I was thinking that someone will tell LGV. I was sure about that. Yes, it is not LGV. It is leishmaniasis. What type? Mucocutaneous leishmaniasis, which occurs secondary to Mexicana or Brasiliensis type of Leishmania species, where Lutzomia is the vector. Lutzomia is the vector. And what is that which is seen in LGV? What is that word which starts from E and which is seen in LGV? It is isthionine. Okay, it is isthionine. So I know these are very confusing words, very difficult for you to remember, but please try to understand them. Please try to understand them in detail. Okay, ji? Very nice, very important. Yes, I will not say, Praveen, that it is clitoromegaly. That is not a correct word to be used. You will call it as genital elephantiasis because of obstruction of lymphatics. Elephantiasis. Clitoromegaly is a completely different condition. Okay, ji? Chalo ji. So we are done with this and we are done with the question also. Let's move to the next one. Are you all ready for the next question? This is our next question on the screen. Very nice, Umang, Praveen. Am I audible and visible to all of you? Please give me a quick thumbs up. Yes. So I don't know what happened. I have plugged on my laptop and suddenly I was lost. Accumulation of calcium in the elastic. Yes, very nice. This is a classical case of pseudoxanthoma elasticum. Very classical case of pseudoxanthoma elasticum. And what is this appearance called as? Any name you all know of? What is this appearance called as? This is known as Moroccan's leather. First, or cobblestone appearance, or chicken skin appearance. Can you tell me where do you see chicken wire appearance? Where do you see chicken wire appearance? Anyone? Yes. Chicken wire appearance is the DIF finding in patients of pemphigus vulgaris. Net-like findings or net-like arrangement of the autoantibodies in between the keratinocytes known as chicken wire, but in pseudoxanthoma elasticum it is chicken skin appearance or cobblestone or Moroccans. You have elastic tissue damage and because of which you have deposition of calcium giving rise to these legs skins near the folds like near the neck. You also see cardiovascular issues in these individuals, and you also see ocular features in the form of angioid streaks. So please remember, pseudoxanthoma elasticum is something which can be asked. And if you remember, recently we had a question from Marfan's disease and Ehlers-Danlos. So all these collagen and elastic fiber disorders are nowadays, like favorite of the examiners. So try to read them little bit in detail. Next question, 55-year-old female gives history of these lesions since 6 years. What is your diagnosis? So she is one of our own patient. We have seen her a few years back. I think when I was in my second year of residency, we have seen this patient. 55-year-old female gives history of these lesions in 6 years. What is the diagnosis? Now she also complained that these lesions are painful and they are suddenly showing increase in the size and change in color. So now I hope you will get the answer. Yes, this is a classical case of melanoma and it is actually a acral melanoma. Acral melanoma, when are you suspecting these lesions? Whenever you have a benign pigmented lesion showing sudden change in size, color, or shape size, color, or shape or symmetry, then you have to suspect a melanoma, and this is present on the acral part. It is known as acral melanoma. Can you tell me what is Hutchinson sign of acral melanoma? What is Hutchinson sign of acral melanoma? Very nice. Hutchinson sign says that whenever you have acral melanoma of the digit, you will see that the pigment is present on the nail and there is extension of the pigment on the surrounding skin also. And this is known as Hutchinson sign. While if you have only the lesion on the nail, it is known as melanonychia. Please give me a quick thumbs up if you understood. Very important for you in your exam for understanding. Amazing. Next question is on your computer screen. Next question is on your computer screen. A newborn with pinkish blue lesion over the upper eyelid. There was no lid edema or eye involvement. There is increase in the size and the lesion regressed spontaneously at about 1 year of age. What is your diagnosis? Sturge-Weber, infantile hemangioma, cherry angioma, or Spitz nevus. Now, please remember the lesion is actually regressing spontaneously, and only one example here regress spontaneously, and that is infantile hemangioma. Can you tell me what is the progression? Infantile hemangioma increased till 1 year of age, and then it starts to regress such that it reduces 50% by 5 years and 90% by 9 years of age. So even if you do not treat these patients, they will heal or they will improve spontaneously. Now, suppose this patient visits you, or if he comes with our parents or his parents, and the parents are concerned about the eye opening. He says that, or the mother says that the baby is not able to open the eyes. Will you give any treatment? Because it will heal spontaneously. But the mother is complaining that he's not able to open the eyes because of the lesion. Then you need to treat this condition. Otherwise, patient can develop diplopia or can have difficulty in vision because of inability to open the another eye. And how will you treat? Please remember, either you will give oral steroids or oral beta blockers, that is propranolol, which is considered to be a treatment modality for infantile hemangioma. Understood, all of you? Bleeding also requires, yes, bleeding. Second is if it is present on the site where it is obstructing the day-to-day activity, like around the mouth, where the patient is not able to eat, around the eyes, patient is not able to see, around the digits, where the patient is not able to work. Only these areas need to be treated. Shatnik, there is no point of doing a pulse dye laser because they will heal spontaneously. You just need to give something which can reduce the progression, and that is propranolol or steroids, a very cheap alternative to pulse dye laser. Pulse dye laser is very costly, and you cannot ask the baby to sit quietly, closing the eyes, cooperating you while you perform your laser. That is not the case. So you need to give something which can easily be given to a newborn or a young child. ठीक है जी? Clear? Understood? Fine, बहुत ही बढ़िया. Very nice. The next question is here on your computer screen. Let me first change my location, and now I'll give you the image. Treatment done only if it interferes. Yes, Tushar. Very nice. You understood the same thing which I have told you. Treatment in infantile hemangioma is only required whenever you have either some associated complication like bleeding, ulcer, necrosis, or if it hinders the day-to-day activity, for example, present on the eyes, ears, mouth, hands, like that. Okay? And third is if patient wants some treatment. Like even if it is not hindering, but if the parents are forcing you, you can counsel the patient, and you can start the infant with the treatment. I think this is a very clear-cut question of chick sign, frequent or a very favorite question of uh, AIMS paper, we have seen this question back to back. This is a classical case of chikungunya fever, where you develop fever, body pain, joint inflammation, followed by very, very classical pigmentation over the nose, which is known as chick sign. Now, you can also develop this type of pigment on the cheek, on the forehead, on the upper lip, and that is why the centrofacial regions are the common site for development of chick sign. Clear, all of you? I hope this question is clear. Anyone has any confusion? Chalo ji. Now here, let us again. I will move my image. Now I think you can see the image properly. Nothing is given. Nothing about the diagnosis. You have to look at the clinical lesion and tell me what will be the treatment of choice. Penile shaft shows multiple nodules. You can see that little bit of eczematous changes on the scrotum is present. So first of all, make a diagnosis and then think about the treatment. Very nice, Renolazine, Samira. All those who are preparing for INI-CT, I do request to please attend my plus course. You don't have much time left for your INI-CT exam. And that is why I recommend all of you to get an Unacademy subscription and try attending the plus courses. All the educators here are trying their best to prepare you well for your upcoming INI-CT. So if at all you are thinking, go ahead and get your subscription today. This is a very, very classical case of nodular scabies, which is very common on the genitals or the scrotum. Can you see here? Can you see here? So what happens in these scabies patients, the treatment of choice is permethrin, which is 5% topical cream. And can you tell me what is the mechanism of action of permethrin? What is the mechanism of action? How is this drug working for this patient? Anyone? Repeat questions. How to or what is the mechanism of action of permethrin here? What channels, Praveen? Which channel? Yes, it is the sodium channel, not chloride. The GABA-gated chloride channel is through ivermectin, not permethrin. And what happens through sodium channels? It causes influx or efflux of the ions, causing paralysis in the mind, causing its death. Okay, Ji, clear? I hope this is clear. Please give me a quick thumbs up, all my dear students. Let's move to the next question. A patient presented with erythematous patch on the flank since 1 month. Which of the following drug can be used for treating this condition? Which of the following drug can be used? Again, nothing is given. You have to make the diagnosis and you have to tell me the treatment. Very nice, Rameshwar, Tycoplanin, Vaishnavi, Umang. Very happy to see. This is one of my own patient. He is responding very well to the treatment. Very happy, satisfied patient. And currently he is only on topicals. And in topicals also I've given just a moisturizer to him because the lesions are completely clear. Can you tell me what is the diagnosis? What is the diagnosis here? Very nice. Who told Phrinoderma Shatnik? What is this site? This is flank of a patient. How can you develop Phrinoderma in flank? Phrinoderma is seen on the extensors like elbows or knee, not on the flank. You can see that here the patient is wearing a dhoti. So that is actually the flank region. And you can see a well-defined salmon colored or erythematous plaque associated with silvery or micaceous scale, associated with silvery or micaceous scale. Please give me a quick thumbs up if you understood, all of you. Please give me a quick thumbs up if you understood. Okay, Prapanjeshwari, Kaustubh, Shatnik, all my dear students. And in psoriasis, what will you choose among the options provided? The answer is vitamin D analog. Can you tell me what is the name of that salt? Anyone? Which is that vitamin D analogs which is preferred topically in a patient of psoriasis? Anyone? The name starts with C. No, Soralin is vitamin A analog. It is not vitamin D. Yes, vitamin D analog is calcipotriol. Okay? Calcipotriol is used as a topical therapy to take care of psoriatic plaque. Okay? Understood all of you? Anyone with any confusion? Yes or no? Badhiya, very nice. So this is one of my own patient, and this patient is also or has also responded very, very nicely. The whole lesion is gone in this patient. Let me see if I have any post image of this patient. You answer this question. Meanwhile, I'll check for the post images. So right now, I'm not able to find the image, but this lesion has been cleared completely. Very nice. Can you tell me what is the diagnosis here? What is this depigmented lesion which is seen in this young child? Yes, this is a classical vitiligo on the face. And in vitiligo, which is an autoimmune T lymphocyte mediated disease, you will give immunosuppressive as a treatment modality. So memoitasone, which is a steroid, it is a immunosuppressive. Tacrolimus, which is a calcineurin inhibitor, and sorelin, which is actually phototherapy. So these are the immunosuppressive agent, but tretinoin, it is a keratolytic drug which has no role in vitiligo, and that is why you will never give this patient tretinoin. Now, few people are writing that it is segmental, few are writing focal. Please remember, this is not segmental, this is focal, because this is not a single segment. Okay, try to look for the different dermatomes. This is not a dermatome, this is a focal vitiligo, because you have multiple patches crossing the midline. On the other cheek also, you had a lot of lesions. So this is a focal vitiligo, not a segment. Understood, Chatnik? Any confusion? Any confusion? No. Chalo ji, very nice. Shweta, Namita, Vaishnavi, Surbhi. So I can see that majority of you are non-subscribed students. So are you all using any other subscriptions, like any offline institute or any other online institutes? Because majority of you, which I can see here, these students, they are non-subscribed students, only attending these special classes. I would request you to try Unacademy at least once. You should at least do it. Anybody of you who is preparing for NEET PG 2022 and who have not subscribed to Unacademy, try to take a shorter subscription of either 3 month or 6 month. Trust me, you will start loving Unacademy. We have amazing educators here, amazing educator. Another feature is nothing recorded, everything is live here. So if you have any doubt, you can just interrupt your educator and ask your doubt. And third is, almost all the educators comes live every day or twice or thrice in a week, which will actually help you discuss the topic or the questions which you have not understood in detail. Clear? So, ma'am, you took classes. Okay, so Prapanjeshwari, I think we should discuss, we should limit our conversation till here only. I would recommend all of you to join Unacademy, because we will be, or I will be coming up with a plus course. I would be coming up with a plus course very soon. It will be in first week of the next month. So if you want to go for a full dermatology course, which will be around 20 hours, I would request all of you to please join this. Yes, Bushra, that will be a rapid revision for INICT. And I think, Bushra, you are a plus student, so that is very, very nice for you. You can directly attend that batch. This is a very classical case of trichotillomania. The dates are not finalized, Bushra. As soon as I get the dates, I'll definitely post it on the group. Okay. Trichotillomania, in this patient, you can see that the lesions, or at the alopecia patch, you can see the hairs of uneven length first. And second is the loss of hair is from the margin. Both these features tell you that you are dealing with a case of psychological hair pulling called as trichotillomania. And for these patients, you need to consult a psychiatrist and you have to give behavioral modification therapy. Otherwise, this will go and can cause scarring type of alopecia. Usually it is non-scarring, but if it keep on occurring, the regular pulling can cause secondary scarring of that area. So you need to take quick action once the lesion starts. Chalo ji. Very nice. Next question is on your computer screen and let's discuss it here. Let's discuss it here. 12-year-old girl with yellowish birthmark on scalp. Her mother reports that the lesion has progressively become thickened. She is asymptomatic, but they are concerned regarding the cosmetic appearance. What is the most likely diagnosis? What is the most likely diagnosis? Pratik, Kaustubh, Fat, Surbhi, Madhu, Praveen, Surya, Aim, Shweta, Lega, Kumar, Prapanjeshwari, Bindu, Tychoplanin, KJ. Very well done, all of you. Very nice. Please remember, this is a classical case of sebaceous nevi. What did I mark? Did I mark option number 4 or something else? This is a very classical image of sebaceous nevi, where you have abnormal proliferation of the sebaceous glands. Okay, and along with that, there is little bit proliferation of the superficial skin. Can you see this patch? Now remember that it is asymptomatic. So if you leave it, it will remain like that. It will not grow. It will only grow in proportion to the growth of the body. It will not overgrow the body's growth. How to treat? Remember, there is no treatment modality. Even if you remove it by electrocautery or radiofrequency cautery, there is a higher risk that it can recur first. And second is there is a risk of scarring followed by the loss of hair, which is seen in these individuals. So you just need to counsel these patients that it is not at all infective, not at all communicable, and it remains like that, only increase till the or only increase according to the body. Yes, hygiene means I've not understood. Like it is not something which is dirty. It is just verrucous like this, and the patient might not get any hairs over it. So you just need to counsel the patient. And I've seen that specifically females come for the removal, but we have seen that on removing it, it recurs frequently and even can get associated loss of hairs over it. Yes, Chaloji. So I think that question is also clear. Now moving to the next one. A pure image-based question, a very classical image of something. 14th November. So what is this, Shweta? Anything which I missed? So I think Bushra is not asking the date of INICT. I hope she's not asking the date. She was asking the date of my course, I guess. Yes, Bushra? Pratik, Shatnik, then we have Kumar, Tychoplanin, Vidashri, Shweta, Bilal, Umang. Very well done, all my dear students. Now, this is a pure image-based question. What did I tell you? Whenever you get a histopath, always try to look for dermoepidermal junction. If you can make out dermoepidermal junction, everything becomes very easy. So let us mark the D junction here. I don't have black color today with me, so what color will I take? Green? No. Yellow, I think it will be visible, yes. So this is the dermoepidermal junction, if you can see very clearly. And you can see that just above the stratum basal, there's a split. So this is a suprabasal split, very classical of pemphigus vulgaris. Can you tell me what is the cleft location in dermatitis herpetiformis? What is the cleft location in a patient of dermatitis herpetiformis? Cleft location in dermatitis herpetiformis. Cleft location in dermatitis herpetiformis. Yes, it is dermal papillary tip. You will see this split only over the dermal papilla at DE junction. Clear? Well, in bullous pemphigoid, you see a linear cleft at DE junction. Clear, all of you? Very well done. Very nice. Very nice, amazing. Now the next question is again, I think a very easy question. You all are aware about this, and I think it's a repeat question. I remember discussing it recently. Primary skin lesion, secondary skin lesion, tertiary. What is this? Can you tell me what is the diagnosis here? Anyone? What is the diagnosis here? What is the diagnosis here? Kaustuv, DR, Tychoplanin, Surya, Samira, Umang, Bindu, Rameshwar, Praveen, Sachi, Faith, Tejashwini, Abhi, Rajat, Vedashri, Tushar. Very well done, all my dear students. Namita, very nice. Please remember, please remember for this particular disease, this is telangiectasia, which occurs because of thinning of the skin secondary to either topical steroid abuse, or it can occur in genodermatomal disorders where you have photosensitivity or sun sensitivity. This is a primary skin lesion, neither secondary, neither tertiary. It is a primary skin condition. True statement. What are these cells? It's a repeat question, so I assume that you all can answer. You can see that separate round cells here. 1, 2, 3, 4. They have a large central hyperchromic nucleus. You have perinuclear halo. Praveen, I'm not able to understand your question. What does it mean? Telangiectasia. Please rewrite your confusion. I'm not able to understand. You all are right. It is a classical Zank smear finding, and these are nothing but Zank cells or acantholytic cells. Okay. Now, what are acantholytic cells? These are the cells of stratum spinosum, which are actually polygonal. Cells of stratum spinosum, which are actually polygonal, but they have lost their intercellular connections and they have attained a round shape. Very classical of pemphigus vulgaris or pemphigus foliaceus. Praveen, there's no vasodilatation in telangiectasia. No. What happens? You normally also have blood vessels in the dermis, but that is not visible because you have a full layer of epidermis at the top. But sometimes, because of thinning of the skin, secondary to either drug abuse or sun-induced thinning, you will see the underlying dermal vessels, and that is known as telangiectasia. Clear? Clear? Okay, okay. Now we have another question, image based. This is also a repeat question, and I want all of you to answer this. Vishnu, the session is remaining for 7 more minutes. It was a 1 hour session, so only 7 minutes left. Diagnosis: warts, lichen planus, psoriasis, or plantar keratoderma. Very nice, very nice. Thick stratum corneum, which is known as hyperkeratosis. Presence of multiple dots. Can you see these multiple blue colored dots? Parakeratosis. We have hyperkeratosis, we have parakeratosis. Collection of neutrophils. This is the collection of neutrophils in the stratum corneum, which is known as micromundo abscess. Then what else you can see? Absence of stratum granulosum. Then just above the dermal papillae, you have suprapapillary thinning. You have suprapapillary thinning. Okay, and you can see that dilated tortuous blood vessels. Am I audible and visible? Am I audible and visible? I don't know what happened. Suddenly my camera stopped working. Dilated tortuous blood vessels in the dermal papilla. In dermal papilla, the blood vessels get dilated tortuous. And that is why when you remove these scales, you see pinpoint bleeding, right? The Auspit sign. All these are the features of psoriasis. Only 15 seconds for this question. I think it's a multiple repeat question. We have discussed this so many times, and I don't know why suddenly my image, it looks as if so many insects are crawling on my photo. Yes, very nice. The wavelength is 365 nanometer, and what is this? This is a classical Woods lamp. Please remember this image, classical image of Woods lamp. Now, I will ask you one very interesting question here. Now, please look at this image. Can you see these red dots? And when I put a glass light, that red dot is completely clear. Can you tell me what is the diagnosis here? Although it's a PG question, but let's see how many of you know about this. This is a very, very classical sign of papular urticaria or insect bite. Like I've seen that in children, specifically in children, you see multiple red color lesions on the lower extremities. Multiple red color lesions in the lower extremities, which is known as papular urticaria. And how to diagnose it? We'll simply use a glass slide and we'll press it. If it disappears completely, it is a papular urticaria. And if you see a little bit of red color, it becomes palpable purple. So this is a very simple sign which is known as diascopy. Can you tell me where do you see Darius sign? Anyone? Where do you see Darius sign? We know dimple sign, we know Nikolsky sign. Where do you see Darius sign? It is urticaria pigmentosa. Amazing. Urticaria pigmentosa, where you see the Darius sign. Urticaria pigmentosa, where you see Darius sign. And I think this would be the last question of the today's session. Very, very quickly, please solve this. This would be the last question. And you all know this. I'm sure you are all aware about this. So this is rituximab. It is a biologic which is used very, very commonly nowadays for pemphigus. And it works by inhibiting CD20, which is present on B cells. And it causes destruction of the B cell. It causes the destruction of the B cell. Clear all of you or not? Please give me a quick thumbs up if you are clear. Very nice, all my dear students. So with this, we are done with the today's session. Anyone has any confusion, please let me know. We are done with the today's session. A lot of image-based MCQs were discussed. I request all of you to please subscribe on Unacademy using the referral code CHESTA10. Please use my code CHESTA10 and get yourself enrolled. You can get shorter subscriptions of 3 months, 6 months, which is very, very useful. And you can even get a longer subscription if you are still in your MBBS and if you are trying for next year or next year NEET PG exam. Okay, ji? Fine. So this is the leaderboard. And with this, bye-bye all of you. Take care. Good day. All the best. I will be taking one more session today at 10 p.m. for INI-CT quick revision. You have all the new pattern question. So please do come at 10 p.m. Sorry, 10 p.m. also. It is a half an hour session from 10 p.m. to 10:30 p.m. So please do come live in evening also. Bye-bye and good day.